So we should probably get started. Good afternoon, everyone, and thank you for joining us for this last session of the day before the dinner, for those of you that can make it there. We are trying in this panel session to bring the topic of the conference into light in terms of data and analytics, and explore together with our panel colleagues ways in which we can disrupt the status quo to bring transformative change in this ecosystem. I am Elena Lungu, and it's an absolute privilege for me to be able to build the data and analytics new function at Canada's Drug Agency. I seem to have a thing for building things from scratch. I've done it a few times, and I'm glad to see a few of my former PMPRB colleagues have joined us today. Before I introduce our panel members, I do want to say that I was touched by the comments and the remarks made by the elder earlier in the session today, and I want to reiterate the land acknowledgement that the CDA has. We recognize the traditional territories' rights and diversity of First Nations, Inuit, and Métis communities across Canada. Indigenous people have been and continue to be excluded from and harmed by Canada's healthcare systems. In the spirit of reconciliation, we are committed to addressing these inequities alongside Indigenous communities. And with that, it's my absolute pleasure to introduce to you the four panelists for this session, offering diverse perspective, representing the patient community, the pan-Canadian health systems, the research community, and the data centers network, as well as the private data and analytics solutions. I wished we would have brought in additional perspective. It is an important topic, and we recognize that there are other perspectives that are relevant to this discussion. It is just the beginning of the conversation. We have to start somewhere, build on some small successes, and then look for momentum. So I do hope this is just the first in a string of discussions that we'll have on this particular topic. So I'll start with Connie, who is the Chief Executive Officer of the Health Charities Coalition of Canada, as well as Brent Diverty, who is the Vice President of Data Strategy and Statistics Division with Canadian Institute for Health Information. Kim McGrail is joining us as a professor in the UBC School of Population and Public Health and Center for Health Services and Policy Research, as well as the Scientific Director of Population Data BC and Health Data Research Network Canada. And last but not least, Brad Millson is the General Manager, Real World Solutions with IQVIA Canada. So just a few housekeeping comments. We have 1 hour and 15 minutes to figure it all out and then go home. But really would like to take a close look in the mirror and try together to do a bit of soul searching and look at how we've done things in the past and what we need to change to get different results. Acknowledging, and I'll probably go back to the comments that Suzanne McGurn made earlier today, that if we can't really afford to kind of stay on the same path as and keep the status quo. The game plan for today is I will take a few moments to provide a brief overview of the data and analytics functions with Canada's Drug Agency. Then I will ask each of the panelists to provide brief introductory remarks that speak to the disruption that they see best happening in the data and analytics ecosystem moving forward. Then we'll try to have a bit of an exchange, drilling further into their remarks. And I hope to have 20 minutes at least of, and I won't refer to it as questions and answers, but more of a comments, remarks from your end. We acknowledge that while we may offer some perspectives, we're definitely not covering the whole spectrum of issues that we need to disrupt in this space. So without further ado, I'll probably jump to the next bit of analysis. I'll just try to cover maybe 7 minutes, not more, of the data and analytics function with the Canada's Drug Agency. I believe I'm speaking to an educated audience, CDA, and prior to that, a few other hats, if I can put it that way, has been around for 35 years. And we have well-established functions. And over the years, we have reinvented ourselves. And more recently, with the December 18th announcement, there have been 3 new functions conferred to Canada's Drug Agency: the appropriate use, data and analytics, and system coordination. And these are the functions that we are further building based on the efforts that have been undertaken by Canadian Drug Agency Transition Office. In addition, there's anticipated 2 new projects related to Bill C-64, and we've heard about that in the plenary session earlier today, on the Act respecting pharmacare around essential prescription drugs and national bulk purchasing strategy. And while the data and analytics function is somewhat unique at Canada's Drug Agency, because we're there not just to support the whole ecosystem, but also to support the various existing and new functions. And we are meeting internally with colleagues, such as from appropriate use, to see ways in which data and analytics can support our functions. Now, oftentimes when I talk to policy decision makers and I ask them what are your analytical needs, they will answer, well, it depends on what kind of data is out there. And similarly, when we ask the data suppliers what data they have, well, it depends on what the question that you need to ask. So we are going oftentimes a bit in circles, so there's a lot of soul searching that we have to do. CADTH, and now Canada's Drug Agency, is no stranger to bridging the evidence supply and evidence demand, and through the data and analytics function, that's exactly what we're trying to do, is to bridge that interface. And we're doing that through a trinity of activities. At a core, our function is as a convener. We are there recognizing that there's tremendous strength and expertise in the system. We're not there to create new structures, to build additional data at Canada's Drug Agency in particular, to create duplication, to swallow anybody in our path. We recognize that there's already a lot of capacity and expertise in the system that resides in various places, and that we need to leverage it, identify it, work together in partnership with the system to provide a cohesive response to the needs of the policy decision makers. So the second aspect relates to our efforts around increasing pan-Canadian data collection, and we're working with our colleagues at CIHI to support them in their efforts to expand the NPDUIS data holdings, as well as provide Canada's Drug Agency with analytical support, as well as looking for ways to collaborate with other partners in that space, such as with HDRN, ICS, to find ways in which we can improve access to data. And thirdly, focusing on enabling robust system analytics. Oftentimes when policy decision makers have questions, they don't know maybe where they should go. In our efforts, we would essentially work with our partners to provide a cohesive and well-coordinated response to the policy decision makers, meeting their needs, identifying what are their policy decision questions, and signaling to the system where the focus should be in terms of analytics. So our vision is to provide a policy-ready drug data and analytics ecosystem that empowers decision makers with access to authoritative, comprehensive, and timely data and insight to improve patient and health system outcomes. And how do we achieve that? Really is looking for ways where we can be disruptive, where we can challenge the status quo and do things in a different way so we gain different results. With the group, we have had the chance to brainstorm on some of the areas that we may want to disrupt, but this is not an exhaustive list. And as I said earlier, we're looking to gain your thoughts as to what are some of the other aspects that we should be disrupting in the data and analytics ecosystem. But we offer these, and we'll try over this session to provide some insight and maybe leave you with some takeaway key messages around these aspects. So first of all, I've been in the data and analytics ecosystem for 2 decades, and oftentimes patients are a unique patient scrambled identifier that is analyzed in aggregate to inform policy decision making. And I hope we've come along a long way from that point to realize that now real insight actually happens when you understand the patient lived experiences. So how do we bring patients from being a passive data source to an active participant in the solution? Secondly, in terms of value, it sounds to me like over the years we've been on a race of acquiring and collecting more data, but is it really about the data or is it about the insights that can be extracted from that data? Privacy, there are perceived real barriers to accessing the data. How can we bridge those? How can we address some of those concerns to ensure that access is there for some of the more difficult data sets to gather, such as around oncology and rare diseases? Governance. Does all data need to be in one place? So we have thought for a long time, but the technology maybe is allowing us nowadays to think in different ways, trying to move from centralized to decentralized. And let's discuss some of the solutions that can be employed there. And similarly, when it comes to harmonization, broad or focused, acknowledging that there's fragmentations. We have way more data systems out there than there are provinces and territories and so on. How do we make them talk to each other? And does it have to be perfect? And is perfect the enemy of good in that kind of situation? So those are some of the questions that I think as a group we have discussed before coming here today. And I'll invite now each of you to offer some of your thoughts, and then hopefully we can entertain some questions. Connie, over to you. Patients are at the center of everything that we do, or should be. Maybe it hasn't always been that way, but hopefully we're moving in that direction. This is a panel discussion around data and analytics. How comes there's a patient in this discussion? What is the role of the patient in data and analytics? And I don't picture you analyzing large access databases of data.
Thanks so much, Elena.
Sure.
So I'm really pleased to be here, and the whole notion of patients as being a disruptor and why we would want to be involved in any discussions around our data, our health data, I think is extremely important. Our health data, and I think, Elena, you mentioned this, but in a very different vein, it's our unique identifier. And so what we want to do is we want to make sure that anyone who is making or helping us, which is what's really key, helping us to make decisions about our health care, is using our information to the maximum ability that they can. And so that's extremely important, but we're also concerned about what data do they actually have about me? Is it just select data? Are they really seeing the whole picture? And unfortunately, in our country and in many countries, we're not gathering the full picture. We only have a slice of what we hope you might need to understand the full complexity of who we are as individuals. And so this might be from the way the clinical trial was run, because as we know, clinical trials are designed to be within a very rigid, controlled space. But this often isn't replicated in what actually happens in the real world. And so what happens in the real world? And does that mean that either that therapy or that device or that particular model, will it actually work in the real world? So I want to use an analogy. Many of you may have walked down a park, and you'll notice that, the park has these well-designed cement pathways that everyone's supposed to walk on. But then you'll notice that along the park are going to be little paths that other people take, because that's the normal route that people would actually travel. And so the urban planners didn't really do their job in including the citizens of that community and really finding out where is the pathway that people typically want to walk, where's the beat of the actual flow of the traffic going to happen in this community. And we see health technology assessments a bit like that, and the collection of data. So it's really a matter of what is it you're collecting, what is the purpose for which you're collecting it, and what is the outcome that you hope to achieve. And we really feel that if you include patient groups from many different areas with many different distinctions, whether it's gender-based, whether it's from different marginalized communities or communities that may not typically be involved in your data collection, we'll get a better understanding of what's really happening. And then we also want to look at different factors. So have you included things like quality of life indicators? So are you factoring in, is this person a smoker? Is this person someone who exercises? All these other things that typically may not be captured in. Are you looking at how often they may be taking the medication? Is it dispensed every 4 hours? Is it once a day? How does that impact it? Where are they taking this medication? Do they need support for that? All those wraparound services that are really critical and crucial to how they're actually going to have success once they get in the real world. So these are all the data points that for us is as significant as some of those other things. And so when we look at patients as being a source of data, yes, you can put us under that microscope and make us fill out all these things and all these tick boxes, but we really want to be a source of those solutions, because we know on the other end, there's so much more. We're so much more complex than just what you're seeing. And one of the pushes that we would really encourage researchers and those who are working in the policy world to work with us on is to really expand your thinking. Include us early on. Allow us to be part of that. What does that clinical trial look like? What might be some other things you might want to measure at the outset that you may not even be thinking about? It may not be on your radar, but it may be really important to be able to measure at the end, but it may not be important initially. And so those are some of the things in terms of that outcome piece that we were talking about. I was having a conversation with one of our colleagues, and we were talking about innovation and what innovation really means. And when we look at data and data collection and innovation in general, innovation is about thinking about things differently. And when she said that to me, I was like, okay, so how do we have to think about data and data collection differently? In this room, I bet almost everyone has some kind of digital, either an iWatch or something. How much data is being collected every day on things that we do all the time? Could this data be relevant to some of the therapies, some of the prescriptions that we get to? And so how can we begin thinking differently? And some of that work's already being done. But there's so much that hasn't been tapped into yet. And so how can we expand some of our sources of data? What else might be relevant that we aren't thinking about? How can we bring that into the fold and into the discussion to expand our thinking? And so it's really about thinking differently about how we do things. Elena, we talked a little bit about, who's missing at that table? How can we reach out to some of those folks? We've seen a huge shift, as I said, in looking at some of the populations that were served and how we're reaching out to some of those communities. How can we ensure that we actually have a voice that represents all these groups? What happens if you have a disease for which there are no comparators? How can we actually begin to do some of that analysis and make sure that we have a proper interpretation of what does this actually mean in terms of being able to do things like reimbursements? Where do we go for that? How can we do this much better? How can we try something new and take that bold risk to do something that's a little bit different? And so we want to really encourage some of the trends that we're seeing and being a little bit more bold and trying something. Safety is important to us, but if we're never going to move the needle and we're never going to have any new innovation and anything new, then we're not serving any of our patients. And so that's my ploy to everyone, is to be bold, try something new, and to really encourage the inclusion of patient partners, or people with lived experience, which we often use in our community, to be part of your process. So I'll leave it there for now.
Sure, and thank you, Connie. Those are great remarks, and I know in the work that we're embarking on, and I'll hand it over to Brent next, the organizations are making effort to pull in the patient lived experience, because as we're evaluating whatever policy there is to evaluate and its impact, you can't possibly do that without that perspective in mind. And I'll turn it over now to Brent. I know we have been collaborating with CIHI, putting in place an agreement that would support the collection of NPDUI's data, but there's so much more that CIHI is doing around partnership with various organizations to change the way in which we and challenge the paradigm of how and reinventing the business model of health systems data. So I'll hand it over to you, Brent, to offer your thoughts.
Great, thanks. Good. So we're really pleased to be part of this panel, support the conference, and to be working in partnership with CDA-ANC in the data analytics space. For those who may not be aware, CIHI, or the Canadian Institute for Health Information, we're an independent agency. We're funded by the federal government, provinces and territories, and we have a unique mandate to support standardized health data, gather and make it accessible, and also to report on health systems across the country and internationally. I think to talk a little bit about where we're going with partnerships, and specifically disruptive partnerships, it's important to understand where we've been and where we're currently at. So just a quick little history lesson of our last 25 years. We were created in 1994 by Canada's health ministers. We have the participation and data sharing agreements with all provinces and territories, including Quebec. We currently have, and the way we've historically seen our data is we have 30 pan-Canadian data sets spanning health services, health workforce, health expenditures. Not just hospital data, but significant coverage, or acute hospital data, but significant coverage of emergency department data, long-term care, home care services, physician billings, public drug claims, et cetera, and some patient data more recently. And we continue to work on increasing the coverage and quality of those data sets and working with data suppliers to try to make that data more recent. We rely on the data that health systems produce, and then we work to standardize it and turn it around. But it does come to us with a certain degree of latency, and we're trying to work on that. Much of the data we have is linkable at the person level, and we're expanding that capability as well as further standardizing and integrating our data for analysis in more of a data lake concept than those historical silos. And you may or may not be aware, we make the data available in a number of ways. We obviously have our public reports and curated views, BI tools and things like that, but we also have, and of interest to this audience, I'm sure, a custom data request program. We fulfill about 400 aggregate and record level data requests annually, and recently we've been able to stand up a secure environment where those data sets can be analyzed with various software tools, et cetera. So more of this is on our website. So that's kind of sets the stage for where we're going, because it's, and I'll just cover a little bit of that. And this is where the concept of disruptive partnerships comes into it. there already exists a lot of health system and health data in the country. But there still are some critical gaps to fill. One of them that Elena mentioned is around the drug data in Canada. So we've got active work to expand. NPDUS now we have all the public drug claims for the country. We're working on gaining access to the private claims, but also cancer drugs, drugs dispensed in hospitals, drugs for rare diseases, and we hope prescription data as well from electronic prescribing services, really to be able to give that full picture and be able to, I think most importantly, link that data to the health services data that CIHI and other organizations hold. We're also working with Canada Health Infoway on some initiatives designed to standardize and improve the flow of primary care EMR data, and ideally make that available in a more comprehensive way for analytics going forward. We call that the Connected Care Initiative. You may have heard of the Interoperability Roadmap. Those are some big new pieces of work that we're working on together in that partnership. We've got some new partnerships with insurers and private sector entities looking to fill some data gaps in the community-based services area. Again, another important area of a data gap. And finally, and I think also equally important, working with partners to enable more disaggregation of data more systematically for looking at issues like equity, inclusion, et cetera. We've got, although there are some critical data gaps, I think that we are also very mindful, as are other, I think, data collectors and data suppliers in the country, of the costs and the burden of data creation. So we've got some work underway there that will hopefully address that, but also really look at trying to decrease the latency in data and key data sets in particular. So we're working with digital health application providers to embed more consistent data standards in their applications in health service organizations and facilitate more direct access to that data through APIs. We're working on some initiatives to support more automated coding and data quality, where health information coders are involved, like in hospitals, for example, and health authorities. We think that can decrease the time and improve the timeliness of, for example, hospital data. We're working with partners like Statistics Canada and Public Health Agency to reduce the amount of duplicate data taking place through linkage and things like that. So trying to really make sure we're making best use of data we have. And finally, and as was mentioned in the previous remarks, exploring the potential for wearables and social media and other data to replace or enhance current data sources. Lastly, I would just say, again, trying to make best use of the data we have and to improve the ability to access it and to share it. We've got some other initiatives that we're involved with at the pan-Canadian level. One is supporting and championing a health data charter for the country that sets out principles for responsible sharing of health data. Organizations are starting to sign on and adopt this, and we think it's a really important step to moving from a model of data custodianship or protecting data to a model of stewardship, which is responsible sharing and appropriate sharing. A second piece of work is a data stewardship framework. We're working with provinces and territories on this, and it's designed, again, for health organizations. Will be an agreed upon and more consistent set of rules for sharing and access, and based on the principles of the Health Data Charter. Also working with health data providers, such as Health Data Research Network Canada, Kim's going to talk about in a moment, to provide more integrated data sets and metadata available through a more coordinated set of entry points and access requirements. So trying to decrease the number of doors and organizations that someone has to knock on in order to gain access to data. And lastly, and very importantly, supporting the increased needs of researchers working with large data sets using advanced data science techniques, HPC, et cetera. So we're trying to figure out our role in that. And really, at the end of it all, everything I just mentioned, every one of those is a partnership with many groups. And not just historically, it's been those who provide us provide CIHI with data, but more and more, it's a broader set of partners at the pan-Canadian level, at the provincial level, patients, Indigenous groups, private sector, et cetera. Partners we haven't worked with before, think partners we have to work differently with. No one organization holds all the data, nor should they. And the job of those who have data to share and responsibilities in the space is to figure out how that ecosystem can function well and make sure the right data is available at the right time for the right purpose. So I look forward to the rest of the discussion. Thanks.
Wonderful. Thank you, Brent. And I know Kim and the group she represents is no stranger to partnership. And ever since I've took on this role, I have been impressed to learn all the work that has been going on at HDRN to collaborate across various entities. So, Kim, perhaps you would like to tell us a bit more about that, and how do you see moving the needle in terms of disrupting the partnership that already exists and building it further?
Thank you. And thank you for the opportunity to be here. It's great to be on this panel with this particular group of people. So I'm, as Elena introduced, I am the Scientific Director for Health Data Research Network Canada. I assume that probably most of you have never heard of us. We're a relatively new organization incorporated as a federal not-for-profit in 2020. We have a large CIHR grant that is bringing together this network of organizations across the country in a bottom-up sort of way to complement the existing capabilities and assets of other organizations, including CIHI. So our members of HDR in Canada are the data centers you might have heard of, ICES in Ontario, Population Data BC in my home province, Health Data Nova Scotia, et cetera, across the country. We have every province, 2 of the territories. We're still working on developing relationships with Nunavut and hoping that we'll be able to bring them in, as well as pan-Canadian partners of CIHI and Statistics Canada. So this is truly a pan-Canadian network. We do not hold data. We are not desiring to hold data. What we are trying to do, as Brent kind of intimated, is breaking down barriers and really doing everything we can in services, supports, new tools, new infrastructure to be able to enable researchers to use data from across the country and to conduct multi-regional research. We are not building anything that already exists, so this is really meant to be complementary to what Brent was just describing. And what he didn't quite use the words, but we have this no wrong door policy, which I think actually came from you to begin with. But the idea is you come to us, and if CIHI can provide everything that you need, then we send you to CIHI or Statistics Canada. The desire for us is to be building a stronger connective tissue across the country, recognizing that we live in a constitutional federation. That is not going to change. So we need to find good ways to help people not have to recreate things every single time you want to do a new multi-regional piece of research. So what I really wanted to spend a little bit of time talking about, this is where I'm going to show that I'm an academic, I guess, is that just to really define some terms and get some basic things on the table. So the whole idea of, I've been doing a bunch of reading on disruptive innovations, and I think disruptive partnerships are a piece of that. So disruptive innovation, on the more radical end of the spectrum of that, is that are innovations that make it possible to do entirely new things and tend to be disruptive, and this is the important part, both to consumers and to producers. So that's kind of market language, but the idea here is that if we're really disrupting something and it's a true innovation, it means that nothing's going to be the same for any of us around the table. And that's not meant to be, and I'm not saying that in a negative way, it's just a reality that we can't just like shove things together and do things as we've always done them and think that that's disruptive or an innovation in a real way. So disruptive partnerships then would suggest that creating partnerships that haven't existed before and working together in ways that have been challenging in the past. And we think that's part of what we've been trying to do with our network, HDR in Canada, is just to make it possible to do the things that we were all trying to do off the sides of our desk. But that's never very successful over the longer term. You can do that in a short-term kind of way, but I'm sure you all have that experience of a really important thing that you want to do, but you're trying to do it in the half hour here or the hour there. It doesn't move things forward in any meaningful way. And I guess maybe everything I've said might sound a bit self-serving because I've given my role with this new organization that really sees itself as being part and parcel of the landscape as it is now. But I do mean to include this other partnerships, for example, the inclusion of patients and public members in everything that we're doing as real partners, not just as groups that we're consulting somewhere along the way. But we're also working definitely with clinicians and health system partners, and trying to bring in the private sector and private sector access and private sector use as well. So I also wanted to talk about a little bit was the kind of assets we have that I would describe perhaps as disruptive assets. So things we already have in place that I think help us to think about where we might be able to go next. So Brent mentioned already the Health Data Charter. How many in this room have already heard of the Health Data Charter? Okay, so see, we have a long way to go on this. So health, that's fine. The Health Data Charter came out of the Expert Advisory Group third report, the final report on the Pan-Canadian Health Data Strategy. So that was sort of the starting point for it. The model for it was the Canada Health Act and 5 basic principles that kind of define how we all work together and what we're trying to achieve with health systems. So it's kind of the North Star. And the idea of writing the Health Data Charter was that we needed to have a common goal, a common view of where we're all trying to get to. When you dig down into the details of how we do that, there could be some disagreements, but if we start with the agreement on the direction we want to go, that would seem to be an orienting piece that we haven't had previously and might help us move things along. Health Data Charter from that report was put into part of the Working Together Better plan. It was endorsed by all provinces except Quebec, although Quebec notionally said they just didn't sign the paper, but they have for sure abide by these principles. And the principles include things like the most fundamental one is that health data design needs to be person-centered, and the data need to serve public good. And that means including private sector access and innovation because that has a public good component to it. They need to have security and safety around them, and we need to make sure that we're living with our principles around commitments to recommendations in truth and reconciliation. So there's 10 principles, easy to read, but that's kind of the main gist of a lot of them. So that's a massive, I think, disruptive asset because we've already done that work of saying, here's things that we could all agree on. Now let's see if the test is whether we actually do all and people sign on to this. So another piece is something that's come out relatively recently, and it's embedded in the Alberta-based Interoperability Saves Lives report, and it has to do with a framework for understanding health-related harm that can come from the use of data. So data-related harm. And I think the fundamentally important thing that this piece points out is harm can come from data use, which I think is part of the reason that we are where we are is because people recognize how much harm has come from data use to marginalized communities and so on. But it can also come from non-use and misuse. And we kind of have neglected thinking carefully about the non-use part of health data-related harm. And so overcoming that in this framework can be helpful for having conversations about it. So that seems like a really good asset. And then the third asset is all of the increasing attention and interest in collective impact. And this is the idea of really bringing partners together and working in a different way, not off the side of your desk, on a common mission with some common structures and supports, communication, shared goal, shared measurement. This is not easy work, but it provides us with a way to think about how we actually form partnerships and the kind of commitments we need in order to be successful with them. The final thing I wanted to acknowledge is that disruption can be uncomfortable as well as exciting. I think about AI and everything we've learned over the last 18 months. I think there's some days you feel more uncomfortable, some days it might feel a little cool and exciting. Disruptive innovations can create chaos that can take some time to settle out. Right? And this is part of the discomfort, is that they are going to change the way that we think about things and work on a day-to-day basis to some degree. They can change markets with some producers exiting and others entering, so it doesn't mean that the same partners you're going to be working with now are going to be the partners you're going to be working with in 10 years, which is also obviously a source of some discomfort. But the most interesting disruptive innovations make entirely new things possible, and sometimes in quite unexpected ways, and that to me is the exciting part. If you can work together and build trust and work in partnership, I think that's the kinds of things we can achieve.
Wow, it's a lot to unpack there, Kim, and I knew I could count on you to provide a lot of food for thought. I will pick on one of the aspects that you highlighted around partnerships and how we expand on that, especially pulling in private, and pass the ball to Brad, who can obviously tell us of all of the partnership that they may have done, or that are looking to change the way they do things to improve some of the solutions that they are offering to the system.
Thanks, Elena, and thanks for the opportunity as well to be here. Kim, I don't know where to go from here. I think you covered it. I think we can all go home. You summed it up really, really well. But I'll try and add a little bit to the conversation.
Always very modest, Brad.
As you mentioned, I'm with IQVIA. IQVIA is, think of it as that logo you see on the freeway as you pass it by, and you think, what is that? And then 30 seconds go by and you completely forget about it. If you haven't worked with IQVIA, you've probably never heard of us. But we're kind of maybe behind the scenes in a lot of things as they relate to driving insight and evidence out of human health and human health data. So our logo or our description is that we're actually a human data science company. It's hard to explain all the things that we do, but if you think about clinical trials, we run more clinical trials than any other organization in the world through IQVIA, obviously sponsored by pharma, but IQVIA is kind of the ones behind the scenes, taking down the charts and qualifying the data. On the flip side, we also ingest internationally large amounts of data around healthcare and how patients move through the healthcare system, how drugs are utilized, and then process that and generate data sets that can be then used to, again, drive insights and hopefully drive change. So if I think about our team, the team that I lead in Canada, you can think of us as kind of researchers for hire. We love to answer questions. We love to solve needs and questions in the Canadian healthcare context, and we kind of use data and analytics to do that. Those are kind of the tools in our toolkit. And if I think about our evolution as a team and as an organization, if you think back even 10, 15 years ago to IQVIA and what we did, it was traditional clinical trials, and from a data perspective, it was very traditional, maybe sales data, maybe some prescription data in there, and kind of very, robust, kind of very high level, right? Not getting to the granularity of the questions that we have today. But if I think the journey that we've had as an organization, it's, I just got started jotting down notes. It's a whole lot of disruption already. And so I was thinking about some of these things, some of the things that we've done, moving from standard clinical trials to pragmatic trials or adaptive trials, to adapt as the trial evolves to kind of improve the efficiency and get at the true answer. Things like using new types of data sources. Our first real-world evidence study using a patient support program in Canada was 10 years ago now. And I remember at the time that caused a lot of disruption, a lot of questions, a lot of, we cannot do this. But kind of solving one problem at a time leads to that change. Some other kind of disruptive things that we're seeing today, the large use of natural language processing. You mentioned AI. That is turning out to be a game changer in how effectively we can go from raw, unstructured information to true insights for patients to drive healthcare decisions. things like de-identification, risk mitigation strategies to address those real concerns around privacy and protecting patient health information while balancing that with the tremendous opportunity to leverage that data for good purposes. So, there are a lot of things that we've done even in the past few years that have, if I think about it, have been quite innovative and quite disruptive. So kind of what are the lessons we've learned so far that maybe we can apply? One is a common thread whenever we've even approached kind of trying to take a new approach to solve a need. One is we make sure that there's not already an approach that exists. So let's not reinvent the wheel. We love to reinvent the wheel in Canada for some reason. How many EMRs do we have? Different, like every province has a completely unique way to deliver healthcare. It's pretty impressive. If you tried, I don't know if you could come up with so many unique ways to
it's like an experiment, how far the creativity goes.
Right? And so, first is let's not reinvent the wheel, but second is let's because the next obstacle you'll encounter is no, that can't be done. Not a whole lot of reason behind it, just no, it can't be. It's never been done, can't be done. So I do think an essential piece of disruption is challenging that no. Why can't it be done? Well, what can we do instead? How can we solve this issue? How do we overcome that barrier? Get to the root of what is actually the barrier and try and find innovative approaches to overcome it. I think that's kind of, out of all the lessons we've learned, that one is kind of key. Because ultimately, when you start to break it down, there's very few challenges that truly can't be solved. Canada's a very intelligent country as a whole. We've got a lot of really intelligent and dedicated people in this room. And, I truly believe that there's not an issue that can't be solved once we really put our heads together. And then the other is getting outside of our comfort zone, right? It's uncomfortable to innovate and to disrupt. It does mean we're going to have to do things differently. That's quite often not a comfortable place to be. Even within my team loves it when there's a clear path forward. But then, once you start innovating, that path is no longer clear. Right? You don't know if you're going to have an answer at the end. You got to be comfortable with it. You have to be comfortable with uncertainty. We can't always know all the unknowables. We still have to make decisions and move forward. So being able to be comfortable in that zone, I think is kind of key. And to that is trust. You got to trust the people. You got to trust the partners. You got to align on common goals. To be able to create comfort in that that unknown. Tying to some of my colleagues' comments around kind of disruption changing things. I agree. Kim, you mentioned it, like disruption is large change, but I think it can always also be small change. It doesn't always have to be the asteroid coming to Earth and we have to figure out how to shift it. It could be, that new coffee machine in the morning, and you're just trying to figure out how to work the buttons. But overall, it's going to make you a better coffee, and you're going to have a better day as a result. So, a lot of the change and innovation that we've done over the years has not been groundbreaking. It's been small innovation after small innovation after small innovation. And then you look back 10 years from now, you're in a very different place than you were when you started. And it was just little increment at a time. So that's a kind of another, be bold, but also take every little innovation that you can get and move the needle a little bit. It's better to do that than try and create this perfect universe in the future that you never get to. Because you'd be surprised how fast you can get to where you want to be by making those small interruptions. I think I'll leave it there, and I'll talk a bit more as we go along around some of the things that we're planning in the future. There's a lot of additional change and a lot of lessons learned from global disruptions that I'd like to talk about. But I think for now, it's
Thank you, Brad. That my heart will always be the private sector, as that has been kind of formative for me back 2 decades ago. But how do you respond to the concern sometimes that private data is bad, may not be authoritative enough, maybe not transparent enough? Wanted to be a bit provocative and hopefully keep the audience alive.
I will make the bold statement that I think all data should be held to the same high standard.
Mm-hmm.
I don't think we should be differentiating from, one source versus another source. As long as you can look at the data, evaluate it, and see, is that data the right fit for the answer or the right purpose for what I'm trying to use it for, right? So one of the common things I hear is like, well, what data do you have? And, this desire to look for the perfect data set. There's no such thing as the perfect data set. Nobody has all the data. Nobody has all the insights about how a patient flows through the system. It is through collaborating and bringing different data sets that we get to see a bigger picture of that. But I don't think inherently a private sector data set is fundamentally different from a public sector data set. I mean, if that were the case, we'd have to throw out all clinical trial data. Because let's face it, most of that is private data. But I do think that we ought to hold the same standard. There's bias from everywhere. We have to acknowledge that there's bias, right? Whether you're a private researcher, a public researcher, an academic, or a government, you've got a bias. You've got your marching orders. You've got your mission statement. You are coming from an angle, right? And so recognizing that and recognizing what the biases are in the people that are analyzing data is also kind of crucial to making sure that you're using the data in the right way and communicating it in the right way.
Right, so irrespective of where it comes from, all data should be held to the same standard. And I know, as Suzanne put it earlier today, there's one source of truth that we can all look at, irrespective of where it comes from. I'm conscious of the time, and I do want to offer the floor for questions. And hopefully, we have offered some perspectives, but I can appreciate that there's probably other perspectives in the room that should be considered. And this is a good opportunity maybe to hand it over to the audience rather than bounce it across ourselves. The question is, how do you see disruptive partnership taking place in the data and analytics space? Where do you see us moving the needle? Very excited. I think in and of itself, the fact that Canada's drug agency has been handed with this new function is disruptive in and of itself. And as part of it, we are looking to build partnerships and strategies to change the way in which we do things, acknowledging that if we want to get different results, we have to start doing things differently. I see a hand up, and thank you for offering your thoughts. Thank you. If you don't mind, just briefly introducing yourself before offering the comments. If we can have some support from the back with the mic, making sure that... Okay, there you go.
Here we go. Okay. Hi, my name's Young Hunt Ao. I work for Green Shield Canada, so we're a private insurance company here. And I was just wondering, I'd like to ask the panelists' views in terms of the opportunities and challenges in terms of working with the private health insurance sort of sector. Thank you.
That is a tremendous question, and thank you for stepping forward. Is one perspective that we would hope to have in the future, amongst others. So I appreciate the question. Sure, go ahead, Brent.
Thanks. Great question. We've had a little bit of experience with this. I think some of the challenges when trying to bring together private and public data. I think one of the things with on the private side that we found is that it's not always the case that data is considered health data, and health data generally has a status under legislation and has sort of some understood rules and approaches to using it. For example, in most provinces and where that doesn't exist federally, there's a provision that that data can be used for statistical purposes for the betterment of the health system. That's not the case when we look at private data, and you're often looking at sort of generalized privacy legislation. So that brings in different requirements and it requires potentially the individual consent, for example, of every physician in the country. And so these are that's one area where I think private data is a challenge to bring it together with and to use it in this way for analysis. And just one other that comes to mind that we've certainly need to grapple with, I think, collectively is finding the value to both parties of such data sharing. So we've had some discussions with private entities about sharing data in both directions, and really it's an important part of that is what's the benefit for both sides. So an example would be with an organization like yours is we'd be quite interested, I think, as a country to better understand in an anonymized way, of course, what types of activities individuals are using. Take a mental health example, and what type of services and supports they're using through their insured health benefits alongside what we have generalized access to, which is public health data from hospital visits, et cetera. So bringing those together to get a full picture of mental health. The question then is how do you do that, and what's the benefit to the health system? What's the benefit to Canadians? What's the benefit to the company? And I think we have to think about that. Is it serving your clients better? Things like that. So those are just two areas, I think, legislation and value that we really have to look at. I think Kim wants to jump in.
If I may just respond to that, because I think there's something in there. I mean, I think there is an importance to basically connect the data just from like a private perspective, and I'm just being like very, very transparent here. Like when we oftentimes receive drug submissions from manufacturers in terms of like the cost effectiveness analysis, this type of things, like things such as the benefits, the costs that are sort of burdened on the private side in terms of like the claims that we're sort of paying. Some of the benefits obviously find their ways in terms of on the public side, such as, the removal of like certain surgical procedures that are done in hospitals, removal of emergency room visits, all this type of stuff. So I think, which is, if I'm being really honest, I think that obviously like discounts the values of medications, and we simply just do not necessarily include those benefits as part of our evaluation. And I think that's kind of a lopsided or a bit of a blinkered sort of view in terms of the value of medication. I used to work for industry as well, pharmaceutical companies as well. I think that the joining of that data in terms of the benefits that are realized across the system, I think probably we need to do a better job in terms of like expressing that and articulating that across healthcare systems, bit where the payment comes from.
Do you need to say anything else?
Fully agree.
And I know this topic is of interest to Kim, and I'm sure to Brad as well. So Kim, maybe you first.
So I'm just going to put more of my cards on the table and say, I think the most disruptive but meaningful thing we could do is actually shift our thinking so that we're clearly accountable to the public for our health system, not to ministries of health or governments. We should feel accountable in every way to people who are using the system. And this is why the first principle of Health Data Charter is that all health data system design needs to be person-centered. So I think the only way we can actually achieve that principle is by bringing in private sector data, because that's the only way we're going to have a comprehensive understanding of the services that people are using or not using. Like this is the only way we're going to really get to really high quality equity analyses, for example. So to me, this is not a decision at all. We have to do this. How we do it is kind of goes to everything that Brent said, which I agree with. It's not going to be easy, but I think we have to get there.
Agreed. Okay. and so you might be surprised, IQVIA, we're probably the largest holder of private sector data in Canada. On our team, I would say the majority, or the majority of studies we conduct today involve partnerships with public. So I think we're already doing it, again, incrementally, one at a time. We've had some really...
Sorry, Brett, public or private?
Private with public.
With public, okay. Perfect.
Combination.
Yes.
Sorry,
combination.
Did I misspeak?
Sorry.
Sorry.
No.
Sorry, my apologies there. So yeah, combination private with public research projects or studies. Things like taking patients from a manufacturer's patient support program, linking that to administrative data to exactly answer the question you have, which is what is the impact that those patients that are on medications that aren't necessarily paid for through the public purse, what's the impact on the healthcare system for those patients? So answering questions like that. And it's not easy, but again, if you tackle it one issue at a time, you can get there. And so that's a big area of work that we do today, and I see continuing. It's this notion that to be able to answer the granularity and level of questions that we're trying to answer about outcomes and inform health, it's going to require bringing in data sets from across the board within the environment.
I'd like to just add one piece to this as a patient representative. And the feeling is that the value of our data increases as long as it's responsibly shared. And so we learn so much more as long as we have those indicators and those protections that are there with it so that the right person is using it for the right purpose, for the right outcome. But if it's not shared, then that information is wasted information because it's just sitting in one repository that only a very select amount of people have access to. So no one's really gaining anything from that.
Mm-hmm.
Completely agree, and thank you. That was a great question. I think there was another question here, more to the front. Oh.
Thanks. I really like where this conversation is going. My name is Carmen Whiten, and I'm with the Women's Health Coalition of Canada. I'm very interested in the discussion in terms of the private data that's being held. And one of the things that was said that I was alerted to quite quickly is that, to get that data would require the permission of every physician. I hope that someday we can get to the point where, as a consumer, as a patient, I can release the data, and that physicians and hospitals aren't the gatekeeper to decide whether or not my health experience can be a part of this knowledge transfer.
Agreed.
Very important comment.
Well, I mean, and one of the big innovations that's happening in this space is around that patient empowerment with direct-to-patient research. So this is going straight to the patient to start to collect that information and generate those insights directly from the patient. I do think it brings the patient profile much higher in terms of kind of their contribution to this and their say in this. So particularly as it starts to relates around patient experience and lived patient experience, patient-reported outcomes, that's a big area of innovation as well. So completely agree with you.
Question over here. Sorry. Yeah, go ahead.
Hi. Yep. Okay. Hi, I'm Stephanie from the Cystic Fibrosis Canada, and I manage the Canadian CF Registry. So I guess jumping on to what Connie mentioned about, just basically linking data sets. We know there's a lot of data sets out there. From the panel's perspective, what are the barriers to data linkage, and how do we make it a smoother process? We've tried to link our registry to a number of jurisdictions, and we're talking like 20 months, 2 years to link a data set of, 1,000 patients. It's quite a long process for researchers, for patient charities that I work for. So just wanted to hear your thoughts.
Sure, and I'm sure every panelist almost has comments on that because there's lots of efforts that are being done to harmonize and standardize the data to address exactly some of those concerns.
Go ahead. You've done something.
The panel's telling me to start. I'm trying to be polite. Well, it's a great question, and I mean, of course, the answer is it depends, and I'll just some really briefly. It really depends on a number of things: what the data is, who's holding it, what the status is under legislation, things like that. Whether it's a consent-based collection, et cetera. So there's sort of you might call those sort of policy and legislative and types of things. There can be some technical barriers. I mean, one of the most ideal things is if you can, if you can do a straight, if you have a unique ID, you can do a straight linkage that, a deterministic linkage, that's great. Sometimes it's probabilistic, et cetera. So I think that if the sort of advice for going forward is trying to anticipate at the start of a data collection what the uses might be, and building some things in from the start is really important. One of the things we often see is consent language for linkage not being written sufficiently precise to allow the types of linkages that are wanted. So for example, we have an example here where because of the way consent language was released, even though it was easy to do the linkage, we had to do 13 separate linkages at the province and territory level as opposed to doing it as one pan-Canadian linkage, even though that could have been done simply because of the language. So I think my comment would be, if you're in it, it's quite difficult to navigate it. It can be done, you can re-consent, for example, but ideally thinking about it from the start and making sure you've got the right things built in.
I think the only thing I would add, and I think CDA is doing some work in this area, but what we shouldn't do is treat all of these as one-off requests. I mean, if we're going to think about patient support programs, registries, all these other things that we want to bring in. I went to a presentation earlier today with the group, CFIN has been working on a framework for patient support program data, kind of thinking both about the structure and kind of commonalities in those data sets, but then also how they might be used. And I think the same is true for registries. If we're going to bring registries in, let's figure out one framework on all the things that are required, help people make registries from the beginning that will be linkable, and then when we actually get to the point of linkage, then your individual registry doesn't get ground up in some long process. So I think shortcutting that is what we want to aim to do.
There's also some resources now, HDRN, it's got some resources, some advice and some, templates and things around this as well that might be helpful for the future, but maybe we could talk after.
Just to that point, I think some of the challenges that we're experiencing, I think this is what you were speaking to earlier, Kim, where when we're making these types of transformative changes, that the disruption here is that we're all going to have to change a little bit. And many of these registries are already existing, have been existing for years, and for many cases have been a key source of information. And so how can we really be able to mine the information that's there, making sure that it does get extrapolated and put to good use, but also being cognizant that there's all these layers of complexity that we have to deal with and not lose the integrity of what was already there.
Thank you, and I think we have time just for a quick last question.
I'll make it short. Thank you. My name is Jessica Inskip. I work with Roche Canada, and I appreciate mentioning kind of the private sector access to provincial data sets, because I think some of our provincial data sets are more open. We know a lot about Ontario and Alberta, and I think as a result, there's more innovation and funding, and then potentially, maybe more clinical trials get placed there. I guess I wonder how we quantify that impact of the innovation of the private sector, and how do we help the other provinces to kind of catch up so that we're working from coast to coast to coast.
Okay. I'll start, and I know you're going to have something to say. So one of the challenges in expanding what ICES has been doing and what Alberta more recently has been doing is simply the receptivity of ministries of health and governments to this. As far as I can tell, and I've been around our Freedom of Information Protection and Privacy Act in British Columbia for a long time, there's no reason that we couldn't do like what ICES is doing in Ontario, but there's a reticence because it's baked into the political thinking that there's this constant antipathy with the private sector, and they're bad, and that's going to be dangerous, and it's going to, but which is ridiculous. Like we need to kind of, I don't know, is this on TV? Grow up a little bit and figure out how to have these relationships. So that this is the disruption that we need, is that we need to bring how are we going to run the the healthcare system of the future, much less the current one we have now, without collaborating with the private sector. This is like, it's a reality. So, and okay, so now the last thing I have to say, because I'm academic, we really conflated the conversation in Canada between private funding and financing of health systems and private delivery of health systems to our peril. I think we need to deconstruct that and have much more nuanced conversations about what private means and how it can be done in a way that does not upend at all the commitments we have in the Canada Health Act to all the values that we hold dearly.
Yeah. You're on a roll. I agree. There's a lot of fear around opening up public data to private sector, right? What's private sector going to do with it? There's, I think, these imaginations of pharma targeting individuals, down the street for, I don't know, whatever nefarious purpose. But I think we need to be better at communicating the benefits here, the what's in it for everybody on this, because there are real benefits to opening up access to healthcare data for patients and the healthcare system. If I think about what we do globally, where these partnerships, there is a lot more reception between private public. Other comparable nations, like in the UK, is a really good example where we're working directly with the health ministries and healthcare delivery within the UK to get to a point of real-time decision-making on healthcare data at the physician level, right? It requires a lot of public-private partnership. A lot of technologies in there, like de-identification, to make sure that patient privacy is protected. There's dashboards to make sure that the data gets turned into something that's actually usable and actionable by a physician. So there's so many benefits to opening this up. We have a group in the U.S. that does extraction of cancer charts and turns them into structured data. And the core reason this technology was created was to help physicians recruit for clinical trials in cancer, which are exceedingly difficult because of all of the parameters that you need for a patient. So us better articulating the benefits and the what's in it for everybody, I think, is important to be able to gain some of that trust.
So a lot of rich discussion, and if I were to kind of summarize it briefly, we have a ton of data. We're sitting on tremendous information that is out there. We also have the technologies evolving rapidly, allowing us to do incredible things with it. I think the barriers that we are actually seeing, we sometimes become our own enemies in that we have built structures that we may think protect some invisible concerns, but as the panelists have presented, we need to find ways in which we can collaborate and bring down those barriers, address some of the concerns, identify what are the benefits to everybody, and not be afraid to be disruptive and bring about change. So thank you very much, everyone. I know we are at times, and I appreciate you spending the afternoon with us. I hope you found it helpful, and CDA is there to continue the work in data and analytics, and we're doing that in partnership with everybody in the ecosystem, and we look forward to hearing from you. Thank you. Thank you. A big round of applause for our panelists. Thank you, Connie, Kim, Brent, and Brad.